As I mentioned earlier, a large proportion of provider revenues doesn't come directly from the patient or the person who's the user of the healthcare services, but from the insurers, and they're known collectively as third party payers. Because the healthcare organization's revenues are key to the financial viability of the organization, it's important that we look at the sources of those revenue in the healthcare industry. So, the major source, the major third party payer, of course, is private insurers. These are the non public insurance companies. So in the US, the concept of public or government health insurance is relatively new. We've only been talking about that. Well, been talking about it for years, but we haven't actually been moving in the direction towards a government funded or universal health care that's funded by the government. So still relatively new in the 20th century. So the majority of the third party payers are still private insurance companies. Another thing to consider is self-insurers. Now, you could say that all individuals who don't have some form of health insurance are self-insurers, but that's not quite accurate. Self-insurers actually make a conscious decision to bear the risks associated with the cost of health care and then set aside or have some sort of fund available to pay for the costs that they may incur in the future. So it's kind of like providing your own safety net versus having the insurance company be the safety net. So not the best idea for individuals, except unless you're very wealthy, because it's hard to have that much money set aside in the event that you need some sort of costly healthcare services. So really hard if you're just the average Joe. Large organizations, often employers, are better candidates for self-insurance. A lot of large companies, and sometimes even not quite so large, maybe mid-sized companies, are self-insured. And the advantages of this is that it has the potential to reduce costs because you're cutting out a middleman. Remember, private insurance is a for-profit business. So this cuts out the middleman, and it offers the opportunity for these employers to offer plans that are tailored to meet the specific characteristics of the organization's employees. So a little bit more variability in what they can offer. So what happens is these organizations that self-insure often pay an insurance company to administer the plan. So for example, a lot of state employees are covered by health insurance and the cost is paid directly by the state, but the plan is administered through a private insurance company. So it just, there's not regular premiums paid, but there's lower administrative costs paid. Public insurers, we've talked about briefly. We're going to revisit Medicare and Medicaid in a minute, but the public insurance, those are the ones funded by the government, and that includes things like we've talked about Medicare, Medicaid, CHIP, TRICARE, the VA services. So we've talked about those briefly. We're going to talk about them briefly again, just to revisit Medicare and probably a couple of things that we haven't talked about. Medicare was established in 1965, and the purpose was to provide benefits to those who are 65 and older. Over the decades, Medicare has evolved and now includes 4 major areas of coverage. Part A is for hospital services and some skilled nursing home facility coverage. Part B covers physician services, ambulatory services, outpatient services, and then also some miscellaneous services in there. Part C is a managed care coverage, and that can be selected in lieu of Parts A and B, so it just alters the coverage and the cost a little bit. And Part D is the newer part of it, and that covers prescription drugs. In addition to those who are 65 and older, Medicare also covers healthcare costs associated with specific disabilities or illnesses, such as kidney disease, end-stage renal failure, regardless of how old the person is. Medicare is a program that falls under the U.S. Department of Health and Human Services, and that department creates the rules of the program on the basis of whatever the federal legislation is. So remember, this is federally regulated. It is administered by the Center for Medicare and Medicaid Services, and that is referred to typically as CMS. Medicaid also began in 1965, and the purpose of Medicaid was to provide a safety net for low-income mothers and children, the elderly, people who are blind, and individuals with disabilities. It is now the largest payer of long-term care benefits and the largest single budget item in many states. So this one, remember, is state run. So it comes out of the budget of whatever the state that it's where the program is. Over the years, Medicare and Medicaid have provided access to services, healthcare services, for many people who otherwise wouldn't have had health insurance coverage. And these programs have also become important sources of revenue for healthcare providers, especially in long-term care facilities or nursing homes, and other providers who may be in areas where there's a large population of people who are low income. But the expenditures for Medicare and Medicaid have grown exponentially over the years, and it's been the topic of and the rhetoric in political debates for decades, how to reform Medicare. We've already talked about managed care, so I'm not going to go over that again. Remember, managed care involves HMOs, or health maintenance organization, and preferred provider organizations. So just review those if you don't remember what those are, but they are important in terms of paying for health care. We're just going to spend a couple minutes talking about different reimbursement methods. So how are healthcare providers paid? So regardless of the payer for a particular healthcare service, so whoever is paying for the services, there are only a limited number of payment methods used to reimburse the providers. And they fall into two broad classifications: fee-for-service, that we're going to talk about first, and then capitation, which we've touched on before. So in fee-for-service methods, there's some variation, but in general, the more services that are provided, the higher the reimbursement, hence the name fee-for-service. You get paid for the services that you provide. There are three primary fee-for-service methods that are cost-based, charge-based, and prospective payment. In cost-based reimbursement, the payer agrees to reimburse the provider for the costs incurred in providing the services to the insured population. It's retrospective in the sense that the reimbursement is based on what's already happened. So the provider provided X service, then they get paid based on the service that they provided. It is limited to the allowable costs, and that allowable cost is usually defined as costs that are directly related to the provision of the services. Okay, so just for all practical purposes, cost-based reimbursement guarantees that a provider's costs will be covered by revenue. So a doctor provides a service, or a healthcare provider provides a service. That service is then billed to the insurance company. The insurance company reimburses what is allowable for those services, and then typically the patient then gets a bill for whatever wasn't covered, or the provider sometimes reduces the cost, and they kind of sometimes just eat the cost that wasn't covered. In charge-based, when the payers pay those billed charges, they pay according to a rate schedule, which is called a charge master, that's established by the provider. So to a certain extent, this reimbursement system places the payers at the mercy of the providers, and especially in markets where competition is limited. The only ones who are, so what happens is the insurers base the reimbursement on the charges that are negotiated or discounted charges. So if you've ever looked at your insurance bill, if you get an itemized bill, and if you've ever been self-insured or didn't have insurance, the rate is higher for those who are uninsured. Because you're insured, you get a discount on whatever services that were covered than if you are paying out of pocket. And the reason for that goes back to those other issues that we talked about, is that pool, and they've got it spread out. They've got the loss spread out over a large number of participants within the program. Think about it if you've ever bought an airline ticket. With an airline ticket, there are only a certain number of people who pay the advertised cost. The rest of the people have negotiated based on whatever program they may belong to or whatever loyalty that the airline offers. They pay a reduced fee because of the utilization of services. And it kind of works the same way with insurance coverage under the charge-based system. So under the prospective payment system, the rates paid by the payers are determined by the payer before the services are provided. Personally, I think you're seeing this more and more. I know that whenever I get services, whether it's healthcare or dental, the provider often calls the insurance company to see what is going to be covered or get it approved by the insurance company ahead of time to know what they're allowed to charge. And they can charge per procedure, per diagnosis, per day, or in a global reimbursement system. Per procedure just means kind of what it says. It's a separate payment is made for each procedure performed on the patient. This can have high administrative costs associated with it, especially when you're talking about some complex diagnoses. So often per procedure is used in outpatient services. Per diagnosis reimbursement, the provider is paid a rate that depends on the diagnosis. So diagnoses that require higher resource utilization are more costly to treat, so they have higher reimbursement rates. So that kind of makes sense. You're not going to get reimbursed at the same rate for someone who goes in for a common cold versus someone who goes in for colon cancer.